Okay. And so the difference is substantial. So if this is, I'd much rather, you would much rather that this is a meningioma. So those are the coverings of the brain. It's like the sheets on the bed and your brain is the bed, okay? And the sheets have a mass, a pillow between the sheets or something like that, pushing in. And so it usually displaces brain rather than invades the brain substance, okay? That's a meningioma. They're typically slow-growing tumors, and they can grow, a few millimeters a year kind of thing, but at some point in time, they get big enough to where they start causing neurological deficits. There's a lot of them that I see that people bonk their head, and there's a little one, and it's incidental finding. You don't need to take it out on the small ones. I see a fair number of those. This one's pretty big, and it's got some swelling around it. You can see that on these images. So it's all this kind of hazy white stuff around the tumor there, okay? And the swelling can be as bad as, or cause as much trouble as anything, as the tumor itself. And that's why you got better in the last 3 days. And we had you on steroids for your back, but they worked for your brain, okay? I think that's pretty much what I would hope and expect if I saw you with this, and I'd say, well, let's get you on some steroids. Usually things get better, at least temporarily. Mm-hmm. Now, what do we do with this thing? I think with one this size, we might need to talk about taking this one out with surgery. It's not my first choice, and it's a heck of a curveball in your course of care, but it is what it is. Now, as far as other tumors, so when we see tumors in what we call the posterior fossa, the cerebellum, there can be tumors that came from elsewhere. So smokers get lung cancer, and that can go to the head. I did a surgery on one of them a few weeks ago. So one way to investigate further is to get a CAT scan of your chest and your belly, and to make sure we don't have a primary lung cancer or something else that we need to keep in mind. It probably won't change my recommendation for surgery, but it could, conceivably, I guess. I'd like to get that CT. It's much faster than the MRI, by the way, but you need the contrast for that. And we'll have to, keep an eye on your kidneys and keep you hydrated because of your kidney disease. But usually one that's this size, that's symptomatic, we usually want to take those out and get the pressure off things. A couple of goals with surgery for that. Number one is to diagnose. What is this thing? What does it mean? Is it a meningioma? Is it a glioma? Meaning the primary tumors of the brain. There are a bunch of different types. Some are more cancerous than others. And there's also metastatic tumors that come from the chest and belly or wherever. Sometimes you don't know where it came from, and it just manifests. So there's a few things that this could be. But with the size of it and, giving you those troubles, and the headaches for that matter. Your headaches got better dramatically, didn't they?
Yes.
Yeah. And that speaks to this thing in the posterior fossa. So surgery for this is very much what I would recommend. The tumor's on the left side there, so I'd go probably off the midline to the left, okay? Make a window. There's a skull. Look back here, and here's the left side, okay? So make a window over here in the bone, okay? Remove it, and then open the coverings of the brain. The cerebellum is that guy in the back, that brown bit, okay? And it sits here. Make sure I don't drop this thing, these are expensive. So this is the cerebellum, and yours is on the left side in here. And go in and remove this thing with microscopes and so on, okay? Once I remove it, okay, we send it for pathology. I'd have a frozen section at the time of surgery. Gives us a pretty good idea. They can tell, say, meningioma from a glioma usually, and from metastatic tumors. So we should have a pretty good idea what we're dealing with. The goal is to take it all out as much as humanly possible. Sometimes you don't get every last cell. There would be, I would say that there's a consideration for other treatments. you know, the big three for treatments for tumors and conceivably, you know, a cancer, which this could be. There's, you know, surgery, radiation, chemotherapy. There are other things, but I would wait and see what the pathology report said, okay? Now, the surgery would take me, I don't know, 3 hours, something like that. A few days in the hospital, but I think, you know, we got to make sure that I'm concerned about how you've been functioning at home, and it's not been that great of late until you got on the steroids. And so before you get out of the hospital, you know, we'd have to evaluate you and kind of like we did after your back surgery, but to make sure that you're safe to go home. I've been concerned about you falling down and everything, and I think we're well down the road of figuring this out. Surgery for this, the incision again's on the, it probably goes to the left of midline a little bit. You'd be asleep with a breathing tube once again, mostly on your belly for surgery. And risks of surgery include infection and bleeding, 1%. There's a small chance that I could hurt you neurologically. The cerebellum is actually quite, I don't want to say friendly, but you can be fairly aggressive in the cerebellum and get a good resection on these and not hurt somebody. You can have some temporary dizziness and imbalance that usually gets better. The risk, there's always neurological risk with any surgery I do. With, motor function, arms, legs, speech function, I doubt it. Vision, the whole laundry list of stroke-like symptoms, but I doubt those would be, would happen. There's a risk of not getting all the tumor out. You might need other treatment, depending on the pathology. There's a risk of spinal fluid leaks with surgery. Okay, especially in the posterior fossa, we worry more about spinal fluid leaks, so we try to get a good closure and all that. We'll be keeping a close eye on that. There's a risk of general anesthesia, and there's always the medical risk associated with surgery. I'll use these images and put them into a fancy computer, whereby I can register this computer and I get a pointer, and wherever I put it on the head, it tells me on the screen where I am very accurately. So it's like a GPS for the brain. It helps us to make smaller surgeries and get to where we're going. It's an adjunct to surgery. Yeah.
So I need operation or something?
I'm sorry?
Yeah. To my
She
head?
says, so my mom's hard of hearing.
Yeah.
She's asking, she's just now realizing you're suggesting a
Yes.
surgery.
We're talking about surgery on your head, back here, okay? Back here, there's a tumor.
You see this, Mom?
that we
Yeah,
want to
because
You
take
see
out.
that white stuff?
Yeah.
That's got to come out.
Yeah.
That's a tumor. We don't know what it is yet.
Because this is the side
That's
I
where you've been
banged my
hurting.
head.
Yeah.
Well, it wasn't, you didn't get the tumor from falling and hitting your head. I
That
think it
could
was
have
the
caused
other
you to
way.
fall.
Right,
That may have caused you to fall.
Exactly.
I got a
So-
question for you.
Yes, sir.
By the way, it's Dr. Harrison. But my question is, somewhere the other night when I was in the ER, I think it was Dr. Heckenberg, I
Okay,
think it was him, said they might have to do a biopsy.
yeah. Well, options for, you know, what do you do with tumors in general? Number one, do nothing, follow it. Okay, well, this one's symptomatic, so I would argue against that. I realize
Okay.
that Norma's 83 years young.
Exactly, yeah.
Right? Because it's probably gonna, you know, you can't take the steroids forever,
Right.
is the point.
Well, I know I've been watching her blood sugar.
Yes, and it makes the diabetes harder, indeed.
Yes, I know.
So one is do nothing and image, serial imaging. Number two is a biopsy. You can go in and, you know, take a biopsy of something, a small piece to diagnose it. I think that's, oh, stop.
But then that would be 2 procedures, basically, right?
Well, I think it's pointless. If you're there, if you're already there and gonna put the time and the energy into it, you might as well take it out. Is the point, and that's why we're talking about surgery. If this were a smaller one that I think we found incidentally at 83 years young, I probably would say, okay, let's, you know,
Just
keep an
watch
eye
it.
on it. We'll get another scan in 3 months or something and see if it's growing or anything.
Well, I think the way I was understanding it is, we got this mass, we don't know what it is, and the best way is a biopsy, and I'm saying, oh, okay, well,
Yeah.
that's the best.
Well, surgery
Yeah,
that
yeah.
I'm talking about is, yes, it's a biopsy, but it's also taking it out.
Exactly,
And
okay.
that's the definitive treatment, I would argue, in this situation, radiation, all that stuff. You gotta know what you're dealing with first.
How big is that window that you have to make for this particular
Oh, I don't know, 3-4 centimeters, something like that.
long, and how wide?
Yeah, usually around.
Oh, it's around.
Yeah.
And how long do you think she would have to recuperate afterwards here in the hospital?
So afterwards, surgery, if we did surgery today, maybe 2-3 days in the hospital, give or take. I'd keep her in the ICU overnight, which I do for cranial surgery, and then get another scan the next day to make sure we got it and see what that looks like. Sometimes you don't get it all, depending on what tumor it is. And then, we gotta work with therapies and make sure that you're safe to go home, or, maybe you need some rehab. I don't know. It depends on how things go. And don't forget, you can have temporary deficits or, imbalance after surgery that can get better. That's from, me mucking around in there
Right.
and stirring things up a little bit. But usually that's fairly short-lived. And so that's where we're at. Thoughts?
Not that it would make personal difference to me, but how many similar types of surgeries like this have you done? I mean, how many do you do in a year? How many have you done just
Yeah.
in your
gosh,
career?
Hundreds.
Hundreds. Okay.
Maybe thousands.
That's what okay.
I don't know. Something like that. It's, but I've done a lot of these, and it's familiar territory. It's not like I did one a couple years ago and the guy did them.
I just want my mom to hear this stuff. And so
Yeah.
the last thing is post-surgery, you put that chunk of skull back.
Yes, so we close the coverings of the brain as watertight as possible. We'll put on some glue and all this stuff that we typically do. It's hard to get the dura closed back here, the coverings of the brain. And then put the skull flap back on with plates and screws and close up. I might go in the midline. I'll look at it again and see.
And then there's stitches in the scalp that would
In
dissolve
the
eventually?
skin, I'll put stitches in the skin. Depending on the closure, I'll decide on whether, I could do staples, sutures, that kind of stuff. Sometimes I do the stitch under the skin, the subcuticular, and you don't have to take them out, but it depends. If I'm worried about the spinal fluid leaking, I may put in suture. And that's a little bit more watertight, if you will.
You said if we did it today, there could be a couple. Why did you say if we did it today? Are you considering?
No,
Oh,
not today.
okay.
That was just a for example.
Yeah.
Okay.
Yeah, so 2-3 days, give or take, depending on how she goes. It's not what either of us wanted, Norma.
I know, you did a good operation to me. Who's gonna go operate you? Okay, because first time I saw you, you said you're gonna make me better.
Yep.
And I'm better.
Well, now you can feel the tumor better.
Right. Well, it's serendipity, how this one came about. It's just weird circumstances.
Yeah.
We fix your back, and then you're kind of struggling, and then you fall down, and then, oh my
See,
gosh,
that-
we found this thing. Who knew?
That's what I was saying. My wife and I were talking. I said, I can't really, I don't know if this is bad luck that she fell and did something to her brain, or if it's good luck that she fell and we spotted something we didn't know was there.
Well, the good luck is that you didn't hurt yourself badly when you fell.
Yeah.
That's the good news.
That's what I was telling her, our floor is kind of a soft floor.
Yeah.
There wasn't no cement underneath or anything
Yeah.
like that.
Well, and the good news is that you didn't, get a hematoma in your brain, a blood clot, or something else that we got to worry about. Or I think this is the cause of your troubles of late, and that's what's been limiting your recovery after your spine surgery.
Okay.
I might have told you this last time I seen you, maybe it was Jennifer I was telling. But after her surgery on December the 15th, everything was fine. Walking,
Yeah, why
We
this
have
thing
just-
went off, I don't know.
everything. And even the therapist said, boy, you're doing fantastic.
Yeah.
And then, of course, she couldn't stand by herself. And that's
Right.
when I made an appointment with your office. And all of a sudden, she did start moving around. So I called and spoke with Elijah and canceled that appointment to say she's getting along great.
Yeah.
2 days later, she's right back to couldn't move again.
Yeah. So the other thing is that, so you're on the steroids. I think I would switch you to a different steroid, and it's called Decadron, dexamethasone. It's a It's a pill similar to the one that you're on, but usually I'd use Decadron in this situation. It is a steroid that can help, but it's, I don't wanna taper you like the box says. So
I
we'll get
can't
you
hardly
some-
read that box.
I know, we'll get you some new medicine. We'll put you on 4 milligrams of Decadron, maybe just twice a day.
And I can
And-
discard the other stuff?
Well, yeah, I think you'd stop it when you get the new stuff, okay?
Okay.
Now, as far as timing, I would want to, try to get surgery done in the next week or two, okay? And you're safe on the steroids, and I think you'll generally find, in retrospect, you'll be like, oh yeah, she's way better. That's typical for the steroids, okay? And so we got to get it going and talk to Annie, and then we'll get you the medicine as well, the Decadron.
Annie is your nurse.
Annie's my nurse, my
Yeah.
scheduler, yeah.
I've talked to
You've
her
met
before.
Jenny as well.
I met Jenny and Ann.
Right.
Can we schedule the surgery today before we leave? Will we know?
Why don't you let Annie call you? I don't know what she's doing right now.
Okay.
But start thinking about things, and we'll, have to shuffle and schedule, and gosh, we've been busy since the new year, but we'll get it done. We'll figure it out.
Okay.
Okay, Norma? We're gonna do a great job for you,
Okay.
okay?
Here's my
And then you-
here's my very last question.
Yeah.
Has nothing to do with
Yeah.
nothing, but my wife and I just bought a motorhome, and our
Plans?
yeah, our first voyage is to take my folks down to Phoenix, April 22nd, 23rd, or the 23rd we'd be leaving. Is there any reason, if we did this in the next week or two, that we should
Put that
postpone or discard our plans? Can my mom travel after this?
It depends on when we get surgery done.
Okay.
I certainly want Norma around. Pretty good chance it does mess with your plans.
Okay.
And the point is, after surgery, especially in the back, in the cerebellum, the posterior fossa, we worry about spinal fluid leaks.
Yeah.
I don't want to send you on the road and you have troubles,
Okay.
and I can't help you out of the state. That's where I got the license.
Gotcha.
So I might politely suggest we try to
Absolutely.
arrange that.
Absolutely. We can do that.
If we can do that.
Yep.
And I want you to do that stuff and all that, but I'm selfish about my wounds. I don't want to push that on somebody else, and they're like, oh crap, that guy in Boise,
Right.
Which facility would you do the surgery here? or-
Here in the basement.
Oh, this
Yeah.
one, okay.
Yeah.
I prefer it.
Yeah, good.
And when this could be happen?
Well,
We'll call, we're gonna start
nurse.
working on that right now. I'll go talk to Annie.
I know,
She'll be
you're gonna-
calling you very quickly.
you're gonna give me a prescription for this new stuff?
Yeah, we can do it electronically for this one.
Actually, if you give me a hard copy prescription, I'll stop at Walgreens on 5 Mile and Overland and pick it up.
If you like.
Yeah, because otherwise I gotta drive to Mountain Home Air Base.
Oh,
That's my
okay.
pharmacy.
I see. Or you can switch it electronically. We can put it to
Because,
whatever. We'll give you the paper one. That's fine.
because it's the 22nd of this month, it's our anniversary for 61.
Oh my
So
gosh.
that's why he's gonna take me.
She wants to go to Las
wherever I
Vegas.
wanna
My dad
go.
wants to go to Phoenix to
Right,
visit his
okay.
sister.
Yeah.
Well, first of all, happy anniversary and good for you. 61 years is a hell of a long time. It's a good thing.
And
Congratulations.
I don't want to get no more operation. I hope it's the last time.
Yep, I agree.
Yeah, but
That's gonna be our goal.
It should solve your problem, that's what we're interested in.
And I want you to go on your anniversary trip, but we might put it off for a month
Yeah.
or so. Okay? I want to make sure you're doing okay.
Okay.
All right.
I'm sorry, doctor. What was your name?
Harrison.
Harrison, Dr.
Nice to
Harrison.
meet you.
Likewise.
When you call over here, Elijah works for him.
Oh, okay.
One of your receptionists over, he's
Elijah.
over there.
Oh, right.
Yeah.
Elijah's about to
And
become
your
my.
first name, sir?
My name's Eugene Boyle.
Eugene.
Yeah, Elijah's about to
All
become
right.
my youngest son's brother-in-law.
Oh my gosh, I got a headache already.
This is Boise, Idaho. We're off. It's almost like
Okay, Norma,
Tennessee.
I'll see you soon, okay? We're gonna do a great job for you and get you out of this, okay?
If I can get that prescription from you, then I'll
Yep.
I'll
Come
wait
on
till
up
we hear
front,
from
and
Ann.
I'll take care of Mom and Dad. You go ahead. If you don't mind, I record it, so if people are gonna ask us questions, and it's a